aorta proximal aberto híbrido ou puramente endovascular?
Again, I'd like to take the opportunity to thank the organizers and the society for the pleasure once again to be in Rio. I've got the charge of picking your poison, the various types of proximal and aortic arch repairs that are available to us. There's replacement of the transverse aortic arch and ascending aorta with open techniques, hypothermic circulatory arrest. You've already heard from Dr. Farber a great deal about debranching with stent grafting across, and then of course there's the, as also mentioned, all the companies are working on totally intraluminal branch graft technologies. I think it's worth to point out that, at least in the United States, within what we've got so far, that of all the pathologies of aneurysmal disease of the aorta, only the degenerative aneurysms are the ones that are on label. Everything else that we do is off label and has to be categorized as such. But having said that, the techniques applied really need to be directed to and are determined by the involvement of the aorta and the pathology included. I think it's worth to note that the pathology of the proximal aorta is rather diverse and includes valve pathology, root pathology, as well as the ascending and transverse aortic arch. And so what are the results of that sort of thing? Recently, aortic valve replacement, less than 3% mortality, composite valve graft replacement, 2 to 7%, aortic valve sparing, 1% frequently less, and even arch replacements are less than 7%. I think it's also worth pointing out that it's fairly rare to see arch pathology when we see it in aggregate with the total aorta, that arch pathology alone without some pathology of the proximal aorta is fairly rare. Mark's already pointed out the various categorizations, and for the most part, what I'm going to be talking about are the zone 1 and the zone 0s. The zone 2s are handled fairly straightforward, the carotid subclavian bypass, and really, from a practical standpoint, it's all about protecting the brain. The various approaches to and the armamentarium that we have for the proximal aorta is diverse. I could show you here from simple valve replacement with separate grafts to a multitude of different composite valve graft replacements, including valve sparing, which is a more commonly applied technology these days, or technique these days. For composite valve graft replacements, Bentel operations, overall mortality rate in this series from Hopkins, less than 1%. This is a institutional registry that we keep on aortic valve versus aortic valve sparing in Marfan patients, and you can see here with almost 300 patients, the operative mortality is about 1%. This is something that's rarely done, just a simple patch repair of the transverse aortic arch. More frequently, we're dealing with proximal aortic pathology with a bevel hemiarch, very, very commonly in the presence of aortic dissection. What's the results of that? Well, it's not very good. As you can see here, the mortality rate, a great deal of IRAD studies, plus others, that the mortality rates are not insignificant in aortic dissection, generally operated upon as an emergency. This is from a German registry showing that in the relatively simple repairs that the mortality rate in aortic dissections in the acute setting can be brought down to around 11%. In the total transverse aortic arch, we've got the traditional sort of patch repair of attaching the brachiocephalic vessels, or the branch open repair popularized by our colleagues in Japan, to now more frequently a multi-branch approach, really sort of pioneered by the group out of Mount Sinai. And of course, for total aortic replacement, there's always been the open elephant trunk. The evolution of aortic arch repair, it's not stood still. We've moved from femoral cannulation to axillary artery cannulation, from retrograde cerebral effusion to antegrade, profound hypothermia to moderate, island techniques to these Y grafts. So the actual open techniques have improved, and they've not been static. This multi-branch debranching of the head vessels, even with open total aortic arch repair, has really been a boom from the standpoint that we can now repair the transverse aortic arch with really zero cerebral ischemia, that we've maintained blood flow to both vessels, to the left common carotid and the innominate and right common carotid, virtually during the entire period of the repair. This is kind of an open technique. We use these elephant trunks previously for open, but now more commonly they're used either antegrade, as shown here, on the right or retrograde from the left. And we've preferred to do this simultaneously, intraoperatively, and we'll use iliofemoral access issues and other things to help us decide whether or not to use an antegrade or retrograde repair, and these are all done in the hybrid suites. This is from 55 of these brachiocephalic debranchings that we did with no hospital mortality, one 30-day mortality and two modest permanent strokes in 55 patients. With regards to opportunities with temperature, in the past we used to cool these patients down to 18, 20 degrees or less. More recently now we cool them only to about 24 to 25 degrees, and with that we've seen improvements in-hospital 30-day mortality, cardiopulmonary bypass time, of course, stroke rates are reduced, as well as hospital stay. This is mortality for aortic arch repair. It's kind of a conglomeration of reports in the literature, and the mortality, as I mentioned, runs about 5 to 7%. With regards to the 0 and the 1, using the hybrid approaches, Mark's already addressed that. As mentioned, you can use this same debranching technique, but rather than doing an open repair, if you've got a proximal landing zone, either from previous surgery with Dacron replacement or a more normal ASIN in the aorta, just simply use the mid to distal ASIN in the aorta as the landing zone for the placement of a stent graft after the head vessels have been debranched. And Mark's already mentioned this. This is something that we rarely do, these carotid-carotid subclavians and carotid-carotid bypasses. We would prefer, in these circumstances, to use a branch off of the ASIN in the aorta of the head vessels, as I showed you in the previous slide. But in patients with a hostile mediastinum and or other significant cardiac issues, this can give you, as Mark mentioned, some additional link between the left carotid and the innominate artery, but by and large in most patients, that doesn't buy you a lot of space. This is a patient who had had previous radiation to the chest, debridement of the sternum for a tumor, replacement of the sternum with a methacrylate, and then had that erode back into the transverse aortic arch, creating a saccular aneurysm here. I would submit to you that for most of us that this would be a very challenging open operation. And due to the left common carotid arising really at the base of the innominate artery, a carotid-carotid bypass in and of itself wasn't going to be enough. So we used the descending thoracic aorta as the inflow through a small left thoracotomy, and then brought that graft up to the brachiocephalic vessels, allowing us then to place a graft across the transverse aortic arch, taking almost an impossible open operation into one which was successful. And this allowed us to go back later and actually remove that methyl methacrylate, have a more direct approach to the transverse aortic arch for just simply patching and covering that, and then reconstructing his sternum. This is a comparison by the group in Phoenix, where they looked at 244 patients with frozen hybrid on pump with hypothermic circulatory arrest with the earlier type of approach that I mentioned, to a debranching off pump with 219 patients. And for all practical purposes, there was no significant difference between the two groups. For hybrid arch repairs, the mortality rate runs about 10%, the stroke rate runs about 5 to 10%, the paraplegia rate about 3 to 9%. The proximal aorta is complicated. It's, as I mentioned earlier, it's not that simple, and as our technology evolves, we're going to have to be able to address that. Now, what are the possibilities? Just very, very briefly, these fenestrated devices are probably a transitional technology. We also believe that the snorkeling and parallel devices are transitional technology, but the branch devices, which all the companies are working very diligently on, and as Mark showed, Cook is well out ahead on that, we believe is ultimately going to be the dominant technology here, and these modular stents do have a role probably in some selective patients. This is an example of a lady with a pseudoaneurysm. The ASIN in the aorta had a previous repair in Florida and was brought to us with this large aneurysm eroding the sternum, and just placing a simple stent graft is quite effective. Roy Greenberg has pointed out that the difficulties in identifying tears and dissections and using this technology for acute dissections is probably going to be sort of the last door to open, with difficulty identifying the tear precisely. Retrograde dissections not uncommon. Presence of other aortic pathologies hinder its use. We've been able to do a lot. We can debranch the head vessels and debranch the abdominal vessels and replace the entire aorta. Just have 2 more slides. Kick it up. We're going to have to evolve. We're continuing to evolve. We just have to be careful and cognizant of exactly what we evolve to. We stand on the shoulders of giants like Dr. Perotti and the work done by Marcelo and Mark Farber here more recently. This is a trip to China that I made with Roy. He used to like to talk about some of his work, building on some of the work that we've did, but I tell you that these days it's more likely this, our standing on some of the work of Dr. Greenberg and others. Thank you.